Religion is an integral part of socio-cultural, economic and political life. However, for many years, international agencies have tended to ignore the role that religions play in the health and well-being of a society. International organizations such as the World Health Organization base their approach to health on modern scientific and secular principles. Religion is often seen as an antithesis of these, and not something to be taken seriously alongside evidence-based and research-led efforts to address health emergencies. Professor Emma Tomalin, the Professor of Religion and Public Life at the University of Leeds in the UK, disagrees with this view.
There is, however, a mismatch between this view of religion at the global level of health and humanitarian systems and how religion operates within the daily lives of those experiencing the highest levels of poverty and inequality, and who are most affected by health and humanitarian crises, such as the COVID-19 pandemic. Within these communities, people are often highly religious, and their religious worldviews play a role in shaping understandings of such crises, including helping to provide a rationale and coping strategies, as well as shaping the decisions that people make about their health.
During the COVID-19 pandemic, many places of worship could not function as usual. The impact of this was not limited to their worship and spiritual activities. Prior to the pandemic, many of these places of worship were engaged in several important outreach work in their communities. The impact of the disruption to this work cannot be underestimated.
For many communities, places of worship are a lifeline, providing food, shelter, and other practical resources, including healthcare and education, as well as refuge and advice for women and girls experiencing sexual and gender-based violence. Just at a time when places of worship were needed more than ever, as sources of spiritual resilience and social service were less able to support their communities. Moreover, when places of worship had been offering support around issues such as sexual and gender-based violence and human trafficking in the past, during COVID, their attention became diverted towards issues arising from COVID, and other services and support systems took a back seat.
Many religious institutions engaged in various relief and support activities during the COVID-19 pandemic. For example, the Swami Narayan Temple in London initiated a national community care program to support individuals and communities during this period. They conducted a series of health awareness programs, delivered meals to vulnerable households, and raised money to donate oxygen concentrators for life-saving COVID relief work in Nepal. They also conducted times of prayer and meditation, which helped develop individual resilience in the face of the pandemic. This highlights the distinctive quality of faith approaches to crises, which combine tangible, practical initiatives with more intangible aspects of faith identity. However, the influence of religion and religious actors during the pandemic was not always positive. Some religious leaders were responsible for the spread of conspiracy theories and misinformation about vaccinations, which had an adverse impact on decisions people made about their health. On other occasions, existing religious tensions and inequalities were intensified.
So in India, for instance, members of the Muslim community were blamed for spreading the virus, building on and exacerbating existing inequalities, where COVID has been depicted, for instance, as a Muslim plot to wipe out Hindus. The result of this has been violent acts committed against Muslims, as well as curtailment of their economic activities, as they've been banned from certain areas and forced to remain at home. And similarly, in Sri Lanka, in both mainstream media and social media, have played an important role in disseminating hate speech, targeting minority communities, Muslims in particular.
In 2006, the World Health Organization published a major study titled Appreciating Assets: The Contribution of Religion to Universal Access in Africa. Against the backdrop of the HIV/AIDS crisis, the study found that the contribution of religion to achieving health goals was significant, with over 40% of healthcare services provided by religious institutions. This approach of engagement with religious institutions and actors to achieve health goals was also successful in polio eradication campaigns and in responding to the Ebola crisis in West Africa. The lessons learned from these interventions led the WHO to engage with faith actors quite early on during the COVID-19 pandemic.
Religious leaders were consulted at the start of the crisis, and guidance was produced with practical recommendations for safe religious practice during COVID-19, as well as engagement with religious texts to promote COVID-19 prevention measures. In addition to this, other measures were taken to embed engagement with religion and faith actors across WHO activities. And we can see this, for instance, in WHO's new information network for epidemics, EpiWin, which has religion as one of the key areas. And you can see this again on the slide here. We're talking about the kind of information that's necessary in order to educate people about how they can protect themselves during COVID, and the various amplifiers or messengers that can get those messages across. And faith-based organisations are very clearly indicated in this model as one of the key actors.
Despite the progress made in the interaction and engagement between international agencies and religious actors, some gaps still remain.
The engagement with faith actors in these different domains has been very much in an instrumental sense. So very much in the sense that what can faith actors and faith traditions do in order to act as resources to serve predefined health goals, predefined development goals, and so on. And also engaging with a particular type of faith actor, so the very formal faith actors who look like NGOs and can speak that kind of development and global health language. The actors at the local level, so the people that work in places of worship or perhaps work with very local faith-based organisations, have been not so strongly brought into those debates and discussions. And that to me seems something that really has to change in order that these systems can be much more reflective of local needs on the ground, rather than just engaging with the same actors that look like the secular development actors in order to keep on replicating the same global north-led models. So I think a lot could be done to move much more to the local level and to hear much more from very local faith actors and local faith communities about how their understandings of health, their understandings of development and so on can influence the global agendas around these topics.